Camillo Porta, del Policlínico San Mateo Fondazione de Pavia, que nos va a hablar de la redefinición del tratamiento de primera línea, el carcinoma metastásico de células renales, cómo aplicar las pruebas más recientes. Camillo, thank you for coming, thank you for being here with us today, and the podium is yours.
Well, thank you very much. Thank you to Dr. Riviera for his invitation. Unfortunately, I realize that I'm on Oncosaurus, which is really terrible for me, but I would apologize for speaking in English, but my Spanish is not so well. So, my task today is to present to you the latest novelties in terms of treatment for metastatic kidney cancer as far as first line is concerned. And I want to start with some biology because we have a few biological features of kidney cancer and of clear cell kidney cancer in particular, by far the most common histotype of kidney cancer, which are quite relevant in terms of therapeutic options. We know that the vast majority of clear cell kidney cancer are either mutated, deleted, or silenced by hypermethylation in the von Hippel-Lindau tumor suppressor gene. This leads to the hyperproduction of a series of pro-angiogenic cytokines, most notably VEGF, which are responsible for that exasperated angiogenesis, which is a well-known hallmark of this cancer. We should also realize that on the same short arm of chromosome 3, where VHL is located, there are at least 3 other genes, PBRM1, SED2, and BAP1, which ultimately may contribute to confer a different biology of kidney cancers. But we have also a completely different type of kidney cancer, the so-called metabolic kidney cancer, which are characterized by mutations in the mTOR gene, leading to increased tumor cell survival and resistance to apoptosis. And a third, but quite important feature is that we are talking about the immunogenic tumor. And indeed, we already exploited these characteristics from the old era of cytokines-based immunotherapy until the recent development of immune checkpoint inhibitors. I want to start with the old ESMO guidelines, 2016, which, as far as first line, suggests the use of either sunitinib, pazopanib, or the combination of bevacizumab plus interferon as standard treatment options for patients with good or intermediate prognosis according to the MSK-CC classification, and temsirolimus as standard treatment options for patients with poor risk features. However, since the publication of this paper, a lot has changed, and I'm going to address what has changed. But first of all, I want to recall you that as far as good and intermediate risk patients, we have 3 standard options that should be regarded as equieffective. Really? Well, if we take a look at the progression-free survival of pivotal studies of both sunitinib, bevacizumab plus interferon and pazopanib, then the results achieved are really superimposable. But we have to take into account that, for example, in the Avoren trial, no significant differences were observed in terms of overall survival. And this is quite striking because if we take into account that for sunitinib and pazopanib, the primary endpoint of the study was progression-free survival, it was overall survival for bevacizumab plus interferon, meaning that from a methodological viewpoint, this study is a negative study, so equieffective, but probably not so much. For sure, sunitinib and pazopanib should be regarded as equieffective treatment options, especially after the publication of these 2 studies. COMPARS, that was a non-inferiority study showing that ultimately the 2 tyrosine kinase inhibitors are equieffective in terms of progression-free survival and overall survival, and the PISA study, which demonstrated that pazopanib is preferred by patients basically due to a different safety profile. So equi-effective in terms of anti-cancer activity, but different safety profile. Ultimately, a clear-cut choice between one or the other VEGFR TKI. As far as temsirolimus, just few comments on its registry trial. These are the curves that clearly suggested that temsirolimus is superior to either interferon alone or a combination of the two in this very peculiar patient population subgroup. However, we have to acknowledge that inclusion criteria changed during study conduction, leading to the enrollment of at least 1/3 of patients with intermediate and not poor prognosis. Furthermore, it is still strange to me the dose of interferon used in this trial that was up to 18 million units. 18 million units for a real poor risk patients is difficult to accept, especially considering that from the early 2000, no evidence of a better efficacy of interferon doses over 10 million units were clearly demonstrated. And furthermore, if we take a look at the control arm of this study, the overall survival observed with interferon alone, that was 7.3 months, was unexpectedly higher as compared to the historical patients treated with interferon at Memorial Sloan Kettering Cancer Center. But despite all these pitfalls, we have also to acknowledge that this was the very first study in kidney cancer demonstrating an overall survival benefit. This is the history. Now I'm going to tell you what changed. But before going to the novelties, I want also to recall you the fact that by means of all these treatments, not limited to first line, but also to second and subsequent treatment lines, we were able to significantly improve the outcome of our kidney cancer patients. As we can see, moving from the era of chemotherapy and cytokines-based immunotherapy to the present era of targeted agents, the expected survival of our metastatic kidney cancer patients dramatically improved, almost doubling irrespective of the risk category considered. So what's new? What's happened in the past 2 years from the time of the latest ESMO guidelines? We have lenvatinib plus everolimus. We have tivozanib. We have ipilimumab plus nivolumab. We have cabozantinib. And we have atezolizumab plus bevacizumab. And I'm going to touch all these studies, and also I'm going to touch a very small study that could be nevertheless important. It was a pazopanib versus temsirolimus randomized phase 2 trial in poor risk patients. For the sake of this presentation, in order to remain within the given times, I'm not going to address safety. I'm just going to talk about activity and efficacy. Let's start from lenvatinib plus everolimus. As all of you know, lenvatinib is a multikinase inhibitor which targets not only VEGF but also another series of cytokines clearly involved in the pathogenesis and in resistance to VEGF inhibition in different tumor types. This study was a randomized phase 2 trial that enrolled patients with advanced or metastatic kidney cancer with typical features, randomized to receive either lenvatinib or everolimus or lenvatinib alone or everolimus. Treatment was continued until progression or unacceptable toxicity. In terms of results, we had intriguing progression-free survival values, but this is important to put the results achieved by this trial into perspective, because for sure The 14.6 progression-free survival achieved in this study was the longest overall survival ever observed in kidney cancer. But we have also to acknowledge the fact that other agents, for example, axitinib or tivozanib, within phase 2 trials achieved very high progression-free survival values. Furthermore, this was just a randomized phase 2 trial enrolling 153 patients, very small trial. And we also have to take into account, despite the fact that I'm not going to go deeply into toxicity issues, that this progression-free survival benefit was achieved at the expense of huge toxicities. And if we go to overall survival, which still is the golden endpoint for us as medical oncologists, although the benefit achieved by the experimental treatment was also evident, the net benefit was lower as compared to progression-free survival. What else in first line? Tivozanib. This is a very intriguing trial and very controversial too. It was a randomized phase 3 trial that compared tivozanib with sorafenib in a setting that was a mix of previously untreated metastatic kidney cancer patients and patients previously treated with cytokines, the same setting of a pivotal trial of pazopanib. Notably enough, the study allowed patients treated with sorafenib who progressed on treatment to receive via an extension study tivozanib. The same was not the case for patients progressing on tivozanib. Keep in mind this because this had a huge impact on study results. The study was positive because it demonstrated a clear-cut and statistically significant progression-free survival benefit in both the overall patient population as well as in patients not pretreated with cytokines, that is, treatment-naive patients. But when we went to overall survival, these were the curves showing the superiority, surprisingly, the superiority of sorafenib with a potential detrimental effect on overall survival of tivozanib treatment. This led to the decision by the FDA's CHMP to decline the registration of tivozanib. And also this led to a huge amount of controversy that was quite well summarized in this editorial on the Journal of Clinical Oncology, claiming for the need of preserving the sanctity of overall survival. But despite all this controversy, ultimately EMA accepted to register tivozanib in the first-line setting. And this was due to, in my mind, very logical considerations. If we take a look at the real study design, including the extension study, it is clear that this phase 3 study compared a monotherapy together versus a sequence of 2 active agents, sorafenib followed by tivozanib. And it is clear, no doubts about that 2 is better than 1, especially considering the fact that this trial was mainly conducted in Eastern European countries, where the availability of standard treatments post-progression was quite low, meaning that it was really a study of 2 active agents versus 1 only. Let's move to ipilimumab and nivolumab, recently presented the results of a CheckMate 1/4 trial. Notably, this study was conducted in patients with poor or intermediate prognostic features according to the IMDC classification and compared a standard of care, that is sunitinib, with the combination of the 2 immunotherapeutics, with an induction phase of 4 doses of ipilimumab together with nivolumab, followed by a so-called maintenance treatment with nivolumab alone. Notably, this study allowed the collection of tissue for PD-L1 testing, although the outcome of treatment in PD-L1 positive or negative patients were just an exploratory endpoint. And the study succeeded, and succeeded quite strongly, because as we can see in these curves, the study demonstrated an overall survival benefit in intermediate and poor risk patients in favor of the combination of immune checkpoint inhibitors. A benefit was also observed in terms of progression-free survival, though the pre-planned statistical analysis didn't reach the statistical significance, but nevertheless the curves differs quite significantly, at least from quite importantly, at least from a practical and clinical viewpoint. And furthermore, the combination of the two immunotherapeutics also induced higher responses, with a notable 9% of complete responses. The effect of the immunological treatments was also evidenced in the overall intention to treat population, where immunotherapy once again was superior as compared to sunitinib. But strikingly enough, if we stick with good risk patients, then sunitinib outperformed immunotherapy in terms of responses, and most notably in terms of progression-free survival. Of course, the results in good risk in terms of overall survival are still pending, but this is a clear message, in my opinion, that we cannot get rid of the EGFR inhibition in all advanced kidney cancer patients. This is a clear-cut message, in my opinion, coming from this study. Then we have cabozantinib. Cabozantinib, as you know, is another multikinase inhibitor which targets not only VEGF but other two pathways quite important, especially in terms of the development of resistance to anti-angiogenic treatments that are AXL and MET. This was a randomized phase 2 trial comparing once again sunitinib as a standard of care versus cabozantinib standard dose and schedule. Once again, this study was limited to patients with intermediate and poor risk features per IMDC classification. And the results once again favored the experimental arm, showing a significant progression-free survival benefit for cabozantinib over sunitinib in this patient population. This is an important result because it's the first multikinase inhibitor which proved to be superior to sunitinib, but this is still a small phase 2 although randomized trial with very few patients enrolled per treatment arm. So very intriguing results, but probably needing some kind of confirmation on larger numbers. Cabozantinib proved also to be more active as compared to sunitinib. And as far as overall survival, we have some kind of discrepancy, because if we take a look at the curves and the relative numbers, we cannot speak about statistical significance. But nevertheless, it is clear, in my opinion, that 5 months overall survival benefit is clinically relevant. And we have to acknowledge that simply this study was underpowered to demonstrate any overall survival benefit. What else? Atezolizumab plus bevacizumab, which is a very interesting study to discuss. Unfortunately, I cannot disclose you the full results of these studies because the final manuscript of the trial has been just submitted, so I'm going to discuss just those results already presented. This was a randomized controlled phase 3 trial that enrolled treatment-naive metastatic kidney cancer patients from all prognosis subgroups, and these patients were stratified by PD-L1 expression status, less or equal or more than 1%, evaluated on tumor-infiltrating immune cells. The study allowed the enrollment also of patients with sarcomatoid features, that is a clearly prognostic negative subgroup of patients. These patients were randomized 1-to-1 to receive either sunitinib, once again, or the combination of atezolizumab plus bevacizumab. The rationale of combining these two agents is connected to the observation that inhibiting circulating VEGF by means of bevacizumab may prime the immune system and allow it to be more activable by means of immune checkpoint inhibitors. Once again, treatment was continued until progression or unacceptable toxicity. Notably enough, the co-primary endpoints were investigator-assessed progression-free survival in PD-L1 patients and overall survival in the intention to treat patient population, while secondary endpoints included progression-free survival in the intention to treat patients, overall response rates, and duration of response. Among the secondary analyses performed, there were also independent review committee evaluation of both progression-free survival and overall survival. The trial ended up to be positive, showing a benefit, statistically significant, in favor of a combination of atezolizumab plus bevacizumab as compared to sunitinib in the PD-L1 positive patient population, which represented around 40% of the whole intention to treat population. The benefit was also observed in terms of progression-free survival in favor of the combination in the intention to treat population, although at a lesser extent as expected. Similar results, and I cannot show you the curves, were observed also in terms of overall survival. Very, very similar results as compared to progression-free survival, which indeed was the primary endpoint of this trial. But, and this is a very delicate point of this study, huge differences were observed between investigators and independent review committee assessed outcomes. Though that statistical significance that investigators were able to demonstrate was completely lost by means of independent review committee, which is a huge pitfall of this trial that we try to address within the discussion, but still remains, in my opinion, something that will probably hamper the everyday clinical use of this trial, of this combination in metastatic kidney cancer patients. Another small trial. This is a randomized phase 2 trial conducted in patients, treatment naive, who had poor risk features according to the criteria originally used in Vitian sirolimus registrative trial. That, as you probably may recall, a slight modification of the original MSK-CC criteria, which included also the number of metastatic sites. Patients were randomized to receive either pazopanib or temsirolimus. From a theoretical viewpoint, this was a very intriguing trial because the perception that pazopanib is a better tolerated tyrosine kinase inhibitor as compared to all the others, especially sunitinib, clearly emerged from both COMPASS and PISCES trial. So the idea of using an agent targeting the most important pathway involved in kidney cancer pathogenesis in a setting of patients with poor risk features, often frail, makes a lot of sense. And the study also allowed the crossover progression between one arm to the other. Unfortunately, the study was close to new patient enrollment as soon as the results of Checkmate 1-4 and Cabosan were presented. And this limited the number of patients enrolled. At the end, a total of just 69 patients were eligible and valuable, 35 receiving pazopanib and 34 receiving temsirolimus. And as you can see, many of these patients were not categorizable as real poor risk when the classical IMDC criteria were used. Nevertheless, the study suggested, because we cannot say demonstrated, suggested the superiority of pazopanib over temsirolimus in terms of both progression-free survival, 5.2 versus 2.6 months, as well as in terms of overall survival, 12 months versus 7.4. But once again, really a limited number of patients and very poor results, suggesting the possibility of a bad patient selection within this small study. But nevertheless, cannot be disregarded in terms of designing the next generation of guidelines. So, I'm going to try to predict the next guidelines for first line. This is just a guesswork on mine, and nothing more than that. Although I am involved in the development of ESMO guidelines, I do not know if these ideas will be translated into real guidelines, but nevertheless, these are my considerations coming from the results that I just showed you. First of all, it is clear, in my opinion, that nowadays we have to take into account IMDC classification in order to stratify patients between good, intermediate, and poor risk. The previous ESMO guidelines consider patients with good and intermediate risk together. Probably we now need to differentiate these patients. Let's start from patients with good risk features per IMDC classification. We have standard options that, in my opinion, should be sunitinib, pazopanib, and tivozanib. But we do also have alternative options. Of course, I'm not giving level of evidence and greater recommendation, because this will be the work of the task force for guidelines. But nevertheless, I think that in this setting, we should take into account to use the combination of atezolizumab plus bevacizumab at least in patients with PD-L1 positive tumors, which raises the issue of the need or not to evaluate PD-L1 expression in kidney cancer patients. Of course, in the hypothesis that atezolizumab plus bevacizumab would be registered, probably we have to do this kind of evaluation. But please remind that to date, PD-L1 expression is still exploratory as a biomarker in kidney cancer, having clearly proved to be prognostic but still not predictive in all patients. Let's move to intermediate risk patients per IMDC. I think that the results of the Checkmate 1-4 study are quite strong, and therefore this combination of two checkpoint inhibitors should be, in my opinion, the standard treatment regimen for these patients. Overall survival benefit, I think that no one can argue against this hypothesis. More complicated is the choice of alternative treatments, because for sure we have cabozantinib, which proved to be active in a setting, but we have also sunitinib, pazopanib, tivozanib, and once again the combination of atezolizumab plus bevacizumab in PD-L1 positive patients. I think that as a committee for ESMO guidelines, we are going to struggle a lot in terms of giving all these options level of evidence and get a recommendation. Would be not an easy task, for sure. And finally, as far as poor risk features, I think that once again, due to the above considerations, EP plus Nivo should be regarded as the treatment of choice, with as possible options cabozantinib, although in real life we should try not to confuse poor risk patients with poor risk by IMDC criteria with poor performance status patients, which would hamper the possibility of achieving any benefit from an active but also toxic agent such as cabozantinib or pazopanib. Not to take into account that many real poor risk patients should be regarded as patients suitable just for best supportive care. One last slide to recall something that was said by Chris Ryan during an educational session at ASCO 2010, and that I recalled in this editorial on European urology, that basically we have a lot of active agents. We can achieve a lot of benefit for our patients by means of use of these agents, not only in first line, but also in second and subsequent treatment lines. But what is key is the way we do use these agents. And indeed, Chris Ryan's simplified algorithm still remains valid today. That is, choose any agent you want, but please use it well. Thank you very much for your attention.
Thank you so much, Dr. Porta. Please join us for the discussion. Bien,